now call upon Jan Parihar to give us talk on principles of wound repair as well as anterior segment injuries. Jan Parihar needs no introduction. He's well known to all of us, and he's been a prolific surgeon and a teacher of teachers. So we look forward to hearing him talk to us about these.
wound repair Good morning. In fact, my job has been made simple by Dr. Shyam Sundar and Dr. Vineet. Corneal lacerations vary in size and shape, can be partial to the full thickness, and range from a simple linear pattern to a complex satellite stellate formations. All lacerations require repair as early as possible, preferably within 20. Restoration of normal anatomy and limiting the amount of post-operative corneal scarring and astigmatism. But so many factors are involved to achieve this. In most of the cases when the injury is extensive or engaging into the pupillary plane optical zone, then obviously a long-term management is very much required. For the diagnosis part, Dr. Ratna has already mentioned about how to go ahead with the slit lamp examinations and other aspects of it, so I need not to repeat it. And obviously the pattern of injury will be fluctuating. A small injury with a hyphema can also give the decreased vision, and a major blow to the posterior pole may not have the reduced vision immediately, but later on with the macular edema it has come. So the ocular trauma, which looks very small, can be a larger one. A small tear can be extended into the subconjunctival space and going up to the sclera. So proper examination is very, very important, and as it is highlighted, the repair should occur urgently to reduce the risk of infection, tissue necrosis, peripheral anterior synechial formation, and alleviate the patient discomfort. Here is very, very important, when you plan repair, you should know your own infrastructure and setup, whether it can be done in your setup or not. If you are expecting that it needs a bigger setup, then it is better to do the immediate to transfer to the place where it can be provided an excellent support. If it is to be delayed because of some reasons, then the primary repair can be done in the anterior segment. So these are the steps. It is not for the ophthalmologist in the larger institutions, but those who are in the periphery, or even for the general practitioners that cover the injured eye with a rigid eye shape. Very, very important, and not to handle or try, if there is a small foreign body which is trapped in the wound, and not to try and pull it up, because you never know how much is the extent. Control pain and nausea with analgesics and antiemetics, patient to refrain from eating, drinking, so because you are preparing for the GA. And remember one thing, for any foreign corneal injuries which is likely to have the posterior segment involvement, it is always better to look for any intraocular engagement of foreign body, and do not perform intraocular pressure if a full thickness laceration is there or suspected. If unsure the laceration is full thickness, perform a Siddle test to confirm it. Depending upon the lacerations, whether it can be under a local and all, it is always better if the injury extent is more, to prepare the patient under the general examination. How to go ahead with whether it is a partial full thickness. So the carefully debrided partial thickness lacerations, after debridement, use a contact lens or fibrin glue to help it to heal and treat similar to a corneal abrasion. If it is a full thickness corneal lacerations less than 2 mm, cyanoacrylate or fibrin glue can be used, amniotic membrane or any to bridge the gap with bandage contact lens. However, a watertight closure cannot be completed, suturing is required. Full thickness corneal lacerations of greater than 2 mm definitely needs suture and should be repaired in the operation. Suturing techniques is basically is to seal the wound as well as to minimize the astigmatism. So remember one thing, that you have to maintain the contour of the cornea, and if you have that in your mind, the topography of cornea, and accordingly to maintain the contour in the central, the suture should not be too big, and gradually in the periphery it may be the larger. So this you can customize accordingly. Two superficial sutures will give the posterior separation, and if you have gone more than 90% of the stroma, it means the 3/4 of the corneal thickness, then you are hitting to the descemet and endothelium, and subsequent you may end up in a corneal decompensation or the secondary glaucoma due to the mid-peripheral synechias are coming. So adequate around stromal thickness of around 90% is good enough to maintain the good integrity and prevent the subsequent astigmatism and excessive scarring. This is a small video clip. Here this is engaging into the partly to the optical zone. So obviously once it is healing, and initially when you give the suture, it should not be very close by to the lips of the wound, because there is a edema. Because of the laceration, the fluid is accumulated, and if you are taking the small bites less than 0.5 millimeter on either side of the corneal lip, probably these sutures may give away when the edema is subsided. Suture should not be too loose or too tight. If you have made a too loose sutures, then obviously when the edema subsides, they become further loose, and infiltration, vascularization and all complications may take place. If it is too tight, then it gives excessive scarring. So you have to optimize, and every time when you are giving the sutures, ensure that the depth of the anterior chamber is maintained either with the viscoelastic substances or with the air or any other tamponade. Knot should be buried. It is ideal to bury a knot simultaneously, and sometimes you find that sutures initially you have given are not fitting into the proper way, so you may remove the suture. If it is wound is extensive, then you can give the two central stay suture, and on either side of the extremes of the lip with stay suture. Later on you replace them. So sometimes you need to give more suture in these cases. Tissue prolapse is a big you may find in the cases, and following the earlier used to be the dictum that where is the tissue prolapse is there, it has to be applied because of the possibilities of infection, or entrapped tissue into the corneal lip may lead to the sympathetic ophthalmitis. But the excision of tissue is not a first choice in the modern ophthalmology, because with the advent of better steroids and antibiotics, these problems are definitely much less seen as compared to the seen 30-40 years ago. It is always how to go ahead with it. One step is that you have to create a small paracentesis from the other side of the wound and inject the viscoelastic. Second, in the lip itself, to separate the bone margins, use the pilocarpine and gently push it inside, then give the stay sutures, and gradually you can reform the chamber. These are the general guidelines for the oblique laceration. Suture will be an equal distance, that as I have mentioned. All corneal sutures, whether it is a corneal transplant or in the repair, it has to be equidistant, but here it is equidistant but not the equi-length. This length will be varying according to the position. The central suture is small, peripheral sutures will be definitely larger in the sense, and the gapping lacerations may place the initial sutures at the end, as I have told you, and then assist gradually in this. This is a very extensive injury, and the second case you are seeing it here is this is the post-RK one. This one is the post-RK 30 years ago, and had an injury 8 months before, and there is a massive disease. Here you see that both the end of the cornea, because otherwise what happens, the cornea becomes ragged and the Z pattern. So that the first sutures are given at the limbus on the both the sides, and then subsequently you give remaining suture. It is basically to maintain the integrity. This kind of how much vision gain they will get it is all the time will say, but the first hour is that we should realize that we are not the best surgeon. There are so many better surgeons than you are available. So the evisceration or the enucleation should be the last resort in all these cases. Primary repair is very, very important, whatever may be the outcome. the second surgeon has a chance, and simultaneously the injury which has given the psychological trauma to the patient and the family, that also will, with the time that those trauma is also being taken care of. So do the exact repair. Tissue loss is that the patch graft can be taken up once the corneal laceration repair is complete. Ensure that there is no leakage, and combination of intracameral supplemental injections, intravena, all these are better antibiotic cover should be given. These are the list of the complications which may take place with any improper surgery, particularly the road traffic accident, contamination, all those are possible. So this is my first